Thank you everybody for joining us and welcome to the next in ASAP's webinar series. We have a wonderful team from Usaid here today to present about advancing HIV prevention to achieve epidemic control. So just a few notices before we begin. Thank you very much for joining us. We love putting on these webinars for our local partners, and so thank you for attending. We have a Q&A box that's at the bottom of your screen. It's separate from the chat box. You can feel free to use the chat to communicate with one another or the panelists, but we do ask that your questions be put into the Q&A box. It really allows us to track the questions and be able to answer them. And in today's webinar, the Usaid team is going to answer some of the questions in writing in the Q&A box, and they're going to answer some live during the webinar. So keep an eye on the box if you've asked a question. And it's also useful to take a look at other questions that have been asked, just to make sure you're not duplicating your question. This says we have 2 polls, but we actually only have 1 today. So at the very end of the webinar, about 20 minutes before the end, we're going to launch a general poll just to ask you how you enjoyed the webinar today and if you'd like similar topics in the future. So thank you so much for doing that. That helps us inform our future webinars. And as always, we have all of the webinars available as a recording on our website. This is the address here, but I'm also going to paste it into the chat so that you can click right on the link. And we have actually a large number of webinars on there in both English, French, and Portuguese. So feel free to check that out. And we're going to go ahead and email a link to the recording as soon as it's uploaded. Usually takes us about a day to get that online for you. So to date, ASAP has, with Usaid support, broadcasted 47 webinars, and we've had more than 9,000 attendees. So again, thank you all so much for attending. We really appreciate it. And here's a few of our upcoming webinars. Our English one is July 28th, and the dates for the rest of ours are upcoming. We just have, we have a new French translator who's going to take on those ones. So we have communication strategies. We're working on one for success stories and how to tell the success of your project and your results in success stories and in your reporting. And then we have business development, and we'll be translating some of the past webinars into French as well. And we have a Portuguese webinar coming up. We're working on the date right now, but it'll be preparing a Usaid budget. And now I'd like to introduce to you Jane Schuler, who is a health science specialist at the Biomedical Prevention Branch of Usaid. Thank you very much.
Great. Good morning, good afternoon, good evening to everyone. Very happy to be here. Thanks, Susan, for the introduction, and many thanks to the ASAP team for helping us to prepare for this webinar. We're very excited to have the opportunity to talk to local partners about our HIV prevention work here in the Office of HIV/AIDS at at USAID. So this morning we're going to focus on advancing HIV prevention to achieve epidemic control. We have a number of colleagues from Usaid Washington on the call who are going to present, and I'll introduce them as we move into the session. But I also want to let folks know that we also have a couple of people who are here in the background: Courtney Irwin, Kate Plord, and Maddie Schneider, who are resource people. So thanks to them for also being on the call, even though you won't necessarily be presenting. We'll be sure to field questions to you as needed. So yeah, good morning again to everyone. Good afternoon. I thought that we would start with just a quick overview of our webinar agenda for today. So if you could advance to the next slide. Great, thank you. So after these quick introductions and the overview for today, we're going to talk a bit about the role of HIV prevention and epidemic control, drawing primarily from the work that Unaids has done across the world. Then we're going to move on to hear remarks from one of our colleagues from the Office of HIV/AIDS to hear about OHA's approach to prevention. After that, we're going to move into really the heart of our agenda. The first part of our webinar is going to focus on evidence-based prevention responses, specifically interventions that include pre and post-exposure prophylaxis, voluntary medical male circumcision, and condoms. That will be followed by a quick Q&A and also some reflections from 2 local partners, in particular IntraHealth Namibia and the Association of Private Health Facilities in Tanzania. After that, we'll move to part 2, where we'll talk about evidence-based prevention responses with a particular focus on populations, including key populations and adolescent girls and young women. That will be followed by a Q&A and also reflections from a local partner in Rwanda, the African Evangelist Enterprise. We'll end the session with any final outstanding comments or questions that you may have, and then one of our colleagues from Usaid will make some closing remarks. So that's our schedule for the webinar, and we can move to the next slide and begin to dive in. I'm going to start by talking about the role of prevention in HIV epidemic control. Next slide, please. I wanted to begin by emphasizing that a focus on HIV prevention is still required. We know that antiretroviral therapy, or ART, and viral load suppression prevent HIV transmission at the community level with a high degree of effectiveness, and we know they're key to reducing incidence and achieving epidemic control. However, modeling has shown that treatment alone will be insufficient to overcome the rate of new infections. In fact, Unaids, in its 2021 estimate, has shown that 1.5 million people became newly infected with HIV in 2020. Far exceeding the 2020 goal of having less than 500,000 new infections. As a result, Unaids' global strategy calls for an almost 80% increase in spending on HIV prevention to enable urgent transformational scale-up of HIV prevention services and to ensure rapid investment in high-impact prevention interventions. Next slide. Thanks. A combination of HIV prevention approaches is most effective. We know that no single prevention method or approach can stop the HIV epidemic on its own. Several methods and interventions targeting key and priority populations have proved highly effective in reducing the risk of and protecting against HIV infection. Those are listed here on the slide: male and female condoms, ART as pre-exposure prophylaxis, voluntary male medical circumcision, behavior change, clean needles and syringes for persons who inject drugs, medication-assisted therapy, and also treatment of persons living with HIV to reduce viral load and prevent onward transmission. During today's call, we'll focus on PrEP, condoms, Vmemc, and we're also going to talk about 2 particular populations, key populations and adolescent girls and young women. Next slide, please. So while a combination of HIV prevention approaches is most effective, and we know which of these interventions have highest potential for impact, there are 4 interconnected reasons that challenge the world's ability to implement effective HIV programs at scale. You know, despite the availability of a widening array of HIV prevention tools and methods, there hasn't been and despite a massive scale up of HIV treatment in recent years, we see that new infections among adults globally have not decreased sufficiently. And this is because of the reasons you see here on the slide: a lack of political commitment, and as a result, inadequate investment in prevention, gender inequality and harmful gender norms that leave women and girls vulnerable to HIV, a reluctance to address sensitive issues related to young people's sexual and reproductive health needs and rights, also a reluctance to address issues for key populations and harm reduction, and finally, a lack of systematic prevention implementation, even where policy environments permit it. Next slide, please. We do know, however, that accelerating HIV prevention is possible. We need to increase national leadership and resource allocation for evidence-informed HIV combination prevention interventions to achieve epidemic control. We must provide access to quality, gender-responsive, age-appropriate interventions for populations who are at greatest risk of acquiring HIV. We must meet the diverse needs of key populations and youth, deliver integrated services that not only prevent HIV, but other sexually transmitted infections and unintended pregnancy. And we must, in our prevention efforts, ensure individuals have access to a wide range of HIV prevention options so they can choose the options that best fit their circumstances and needs over time and with different partners. So at this point, next slide, please. I'd like to turn it over to Allison Chang. Allison is our Deputy Division Chief for the Prevention, Care, and Treatment Division at the Office of HIV/AIDS in Washington. And she's going to speak a bit about OHA's approach to prevention. Over to you, Allison.
Thank you, Jane. And again, good morning, good afternoon, good evening, everyone. We're really glad that you could join us today to talk about HIV prevention. So just following on Jane's presentation and the Unaids call to action around prevention, I did want to note that, yes, we have 1.5 million people who unfortunately became newly infected with HIV in 2020, but that's not equally distributed across geographic areas or populations. Southern and Eastern Africa accounted for 670,000 new infections in 2020. Asia and the Pacific accounted for 280,000 new infections. And of all of those new infections, women and girls accounted for about 50%. So we know that within our work to better address the prevention needs of the populations we work with, we know that, again, not all risk levels are the same, depending on where you live and what other risk factors you may have. Next slide. Usaid invests in a number of primary prevention areas, both priority interventions as well as populations. And I'll just go over a few of them here today, and then we'll learn more about some of them during this webinar. On the intervention side, our priority areas include pre and post-exposure prophylaxis, often referred to as PrEP or PEP, respectively, voluntary medical male circumcision, male and female condoms and lubricants, new and novel products and methods for prevention, such as the dapivirine vaginal ring or long-acting injectable cabotegravir, prevention of mother-to-child transmission, and harm reduction in medication-assisted treatment. We also have several priority populations. And very importantly, we serve a number of key populations. That includes men who have sex with men, female sex workers, transgender people, people who inject drugs, and people in prison and other closed settings. Another really key priority population for us at Usaid is also adolescent girls and young women, and then orphans and vulnerable children, and some other priority populations as well. The programming areas that are bolded on the slide are the ones that we'll cover in the webinar today. Next slide. And finally, I just wanted to highlight some examples of leadership in HIV prevention from Usaid and also from our implementing partners. First off, we're really, I think, at the forefront of community-based, innovative, and client-centered HIV prevention services and structural interventions for key and priority populations. So working not just at the individual level, but also at that structural level in the policy rights and policy and rights space as well. We're also a leading PEPFAR Dreams implementer serving the needs of AGYW. We are really, as an agency, Usaid and our implementing partners have been leading the introduction scale up of innovative HIV prevention products. And in the past, that's included PrEP and Vmemc, and currently and in the future, we know that will include the dapivirine ring or DVR and long-acting injectable cabotegravir, also referred to as CAB-LA, and then other novel approaches to service delivery, including differentiated service delivery and private sector engagement. Usaid has also been actively at the forefront of programming for condoms, including multilateral engagement and alignment of condom programming and priorities. We also work on integration of prevention with other health areas, and in particular, family planning and maternal and child health. And then finally, in the past year and a half, Usaid and our partners in the field have been working to rapidly adapt our programs to the COVID-19 pandemic and to ensure that our beneficiaries still have access to essential prevention programming. Next slide. So just in closing, I'll just also note that, for prevention in particular as a program area, measurement of impact and outcomes is particularly essential. I know that our our other presenters will go in more detail on the ways we measure prevention, but this slide is just here for reference for all of you in the deck. And with that, I will wrap up and hand it over to the next presenter. Thank you.
Thanks, Allison. Really appreciate it. Before we move on to the first part of our technical piece of the agenda, I just want to check if anybody has questions or comments. You're most welcome to add your questions to the Q&A box. And also, I just wanted to note that as attendees, you can like the questions in the box, and those will also move that question up higher for priority in terms of questions that are most popular. So feel free to add any questions or comments you have in the Q&A box. We're here to answer those in writing or to even discuss them verbally during the session. So just want to encourage people to do that. Okay. So for now, I don't see any questions, so we'll move on. As I said, now we are really getting into the meat of today's session. In part one of the webinar, we're going to talk about evidence-based prevention responses with a particular focus on interventions. We'll start first with pre and post exposure prophylaxis, moving on to voluntary medical male circumcision, and then condoms. Next slide, please. So to start us off, I'll hand it over to Jennifer Duncan. Jennifer is one of our star HIV PrEP interns. She's with us over the summer, working with us on our biomedical and prevention team, and we're really excited to have her here today presenting to you on both PrEP and PEP. So Jennifer, over to you, please. Thanks.
Thank you, Jane. As mentioned, my name is Jennifer Duncan, and I'm very excited to be talking to you all today about pre and post exposure prophylaxis, also known as PrEP and PEP. I'm going to start with a basic refresher on the difference between PrEP and PEP. I'm sure this is common knowledge for many of you, but let's just go ahead and jump right on in. PrEP is taken to prevent HIV acquisition before exposure, while PEP is taken to prevent HIV acquisition after suspected exposure to HIV has occurred. For those of you, if any, that PrEP is a new concept, I highly recommend the video linked to this slide. It's an excellent resource for a deeper dive into PrEP, but unfortunately, we don't have time to show it today. Next slide. Moving on to the Usaid PEPFAR technical priorities for PrEP and prevention. PEPFAR's aim for COP20 is the global scale-up of PrEP. PrEP is a proven scalable intervention which can drastically reduce the rise in new HIV infections in many places where PEPFAR works. Therefore, in COP20, PEPFAR made PrEP a core programmatic requirement and set a goal of reaching 1 million people with PrEP in fiscal year 2021. With a focus on those at the highest likelihood of HIV acquisition, which includes key populations, adolescent girls and young women, pregnant and breastfeeding women, serodifferent couples, and anyone requesting PrEP. In addition, focus was placed on PrEP scale-up and HIV testing in the most at-risk groups. Through this link to testing, PrEP programs will also contribute to PEPFAR's efforts to ensure that all newly identified people living with HIV are immediately linked to the full range of prevention interventions. Another technical priority is the implementation of client-centered approaches to better serve individual needs and differentiated service delivery, such as multi-month dispensing and community drug dispensing lockers to ease access to medication refills. One of those lockers can be seen in the picture on the slide, which was taken at the Key Populations Program in Pretoria, South Africa. Lastly, Usaid PEPFAR new HIV prevention products as they are introduced. Next slide. To track progress towards our targets, it's imperative that quality data is collected. PrEP is measured through two MER indicators, PrEP new and PrEP cur. PrEP new is defined as the number of individuals newly enrolled on PrEP to prevent HIV infection in the reporting period, while PrEP cur is defined as the number of individuals inclusive of those newly enrolled to PrEP to prevent HIV infection. Both indicators are reported quarterly and disaggregated by age, sex, and key population. However, PrEP cur also requires 3-month test results, which looks at if an individual is HIV positive or negative less than 3 months since PrEP initiation. PEP is part of the gender-based violence indicator and is defined as the number of individuals receiving post-gender-based violence clinical care based on the minimum package. The indicator can be generated by counting the number of persons receiving post-gender-based violence clinical care and is disaggregated by the age group and sex of the client receiving services, as well as the type of service, which includes sexual violence or emotional physical violence, and PEP provision. Any process to determine PrEP eligibility should include questions about a client's risk or exposure to gender-based violence and intimate partner violence, with appropriate interventions or referrals provided as needed. It's really important to note that a client coming for PEP may be a good client for PrEP as well. Next slide. Now let's look at some of our global trends. As mentioned in COP20, PEPFAR made PrEP a core programmatic requirement and set an overall goal of serving 1 million people. As of Q2 for fiscal year 2021, we have reached 39% of PrEP new targets globally. Looking at the data presented in this graphic, we can see that this already exceeds the total PrEP initiations from the previous COP year. Next slide. In addition, as of Q2, we have reached 46% of PrEP cur targets globally. Having reached over 600,000 individuals with PrEP, we are well on our way to PEPFAR's goal of reaching 1 million people. It's important to note, however, that PrEP cur only counts the number of individuals that receive PrEP at any point in the fiscal year and doesn't tell us how many times someone returns for services or stops and restarts. Next slide. Thank you. Looking at Pep Trends, it is important to note that for COP21 fiscal year 2022, PEPFAR has made PEP a part of PEPFAR's comprehensive HIV prevention package. And any process to determine PrEP eligibility should include questions about a client's exposure or risk of gender-based violence. As mentioned, all individuals that report that they have experienced sexual violence should be offered. Go back to this last slide, please. If you could go back. Yeah. All individuals that report that they have experienced sexual violence should be offered PEP. It's also important to note that experience of violence does not make one ineligible for PrEP. PEP is not a substitute for regular use of other HIV prevention strategies. Therefore, the key takeaways is that PEP is an additional HIV prevention tool and a key component of PEPFAR's comprehensive HIV prevention package and the minimum package for post-violence clinical care services. However, PEP is not often readily available, and many countries only have outdated PEP stock, such as old ARVs that they use. Greater support for PrEP use in HIV programming is needed. Moreover, completion of PEP regimes is often poor because of trauma faced by survivors. We still have a long way to go with PEP, and we need to improve the delivery of PEP under gender-based violence services. But we should also make it available to anyone beyond those services as well. Next slide. Thank you. So I want to conclude by looking at some of the key challenges and opportunities we have going forward. Challenges include, but are not limited to, policy limitations, including PrEP provision being limited in certain populations due to stigma and restrictions in some contexts on community delivery of differentiated services for PrEP. In addition, stock and supply chain issues are common. This has also been seen due to COVID-19 with countries rationing of stock, and also ARVs for PrEP not being considered during supply chain planning, as well as poor management of supply chain and stock across sites. Also, as many of you, I'm sure, have noted, COVID-19 restrictions have halted or slowed programs in many areas, and there has been limitations in COP budgeting for PrEP expansion. In addition, continuing limitations of training and support of providers has also been another challenge. To combat some of these challenges, we can look at ways we can move forward with PrEP scale-up. This includes leveraging partner innovations and strategies, many of which were adopted and accelerated during COVID-19. Successful adaptations include using technology such as online screening and reservation apps, and continuing to promote differentiated service delivery. This will help decongest health facilities to support PrEP access for clients, as well as make it easier for clients to have access to the services they need. In addition, we need to continue to advocate for co-funding of PrEP by ours, while leveraging virtual platforms for increased provider training. Moreover, introduction of new biomedical prevention technologies that are in the pipeline, such as DVR and CAB-LA, will provide additional choices for HIV prevention options. Next slide. Lastly, I just want to leave you with a list of valuable resources for further information on PrEP, which includes the PrEP Learning Network, which has a monthly webinar series, the West Africa PrEP Learning Network as well, WHO and JPIGO, and PrEP Watch. These are all really good resources. They have a lot of information, and I hope that you'll check them out. Thank you very much for your time, and I will pass it back over to Jane.
Great. Thank you so much, Jennifer. I see we have a couple of questions in the Q&A box. If anyone from our team wants to answer those, you're welcome to do that. If not, we'll return to them at the end of this particular part of the session. I'd now like to turn it over to Valerian Kigundu. Valerian is our voluntary medical male circumcision technical lead at the Office of HIV/AIDS, and he's going to go through Vmemc for you today and talk about some different country experiences. Thanks. Over to you, Valerian.
Thank you, Jane. Good morning, good afternoon, everyone. I'm honored to speak to you about Vmemc for HIV prevention, particularly how local partners are now making contributions to this OD program intervention. Next slide. We'll start off by reviewing our COP20 and COP21 priorities. We have two specific funding years in there because priorities don't change that much. And once you have COP guidance, we start already implementing some of the new updates. So we have 5 key priorities for Vmemc. The first one is age pivot. Somewhere towards the end of COP19, there was changes in age guidance. So we wanted to make sure that we ensure full compliance with the PEPFAR age guidance established back then. The second key priority is safety and quality of services. Our goal is to ensure Vmemc services are of the highest quality, and client safety remains #1 priority. The third priority is program efficiencies for success. Sometimes we call this above site. But the goal here is to first track above site efficiencies to refocus and align the Vmemc program with the COP20 guidance, specifically in ensuring adequate commodities, staff competence, mostly provider training and user training, especially on new devices, especially shangling, advanced event monitoring, and CQI scale up. CQI is continuous quality improvement. The fourth priority is mitigating the impact of COVID-19. As you know, Vmemc being a committed program is one of the programs that has been mostly affected during the pandemic. So our goal here is to accelerate safe reopening and implementation of Vmemc services during COVID-19 by adapting successful demand generation approaches and monitoring compliance and performance. Then lastly is to leverage G2G for Vmemc sustainability. Specifically, our goal here is to identify activities and resources to support Vmemc sustainability. Next slide. Once we got COP21 guidance, we were keen to see what was new. So on this slide, we highlight what is basically new. And of note, PEP guidance and reusable kits have been re-emphasized in COP21. When it comes to age guidance and related specific activities, of course, I talked about the ensuring age guidance established back then continues. Our target is to ensure that we target clients who are 15 years and older. Can you go back a few slides? Okay, thank you. We also, during this COP21 guidance, specifically there are changes, there are emphasis related to clients 13 and 14 who may be approved for shangling in terms of an exception. Truly informed consent must be ensured, especially for clients who are under the age of 18 years. Shangling safety monitoring is also now emphasized, and device displacement for clients where shangling is used is now a notifiable adverse event reportable to OGAC. Other guidance, mostly what is important here is to where we are transitioning to reusable kits, HTS, HIV testing services, ensuring that it is targeted. Vmemc being a prevention program, most of our clients are negative, so we need to ensure more efficiency in testing so that we target clients who are at risk. HIV index testing at Vmemc facilities and cervical cancer screening where applicable. Next slide. On this slide, we review briefly some of the indicators used to monitor the Vmemc program. Vmemc has two main indicators, and overall, it's one indicator that is monitored mostly. The Vmemc SAC collects data on number of Vmemcs conducted during the reporting period. It's collected quarterly and annually. It is collected at the facility and country level. It has for disaggregates age, HIV status, Vmemc method, surgical device, and Vmemc follow-up. Our goal here is to ensure that clients are followed up at least once in 14 days. The second indicator, which is the Vmemc AE, which was officially listed from most of the programs, is now collected at the level of SGAC. For notifiable adverse events, there is a specific number of adverse events once encountered are reportable to SGAC. Other indicators which may be moderate or severe are reported at the country level and using custom indicators to be reported at AQ. Next slide. So on this slide, I would like to walk you briefly through some of the local partners that are supporting the Vmemc program. Unfortunately, most of our partners started implementing services during the pandemic, and they have experienced unprecedented challenges. But what you see in blue are the local partners who are prime partners in their countries, and below in orange are the local partners that are either having transition awards or their sub-partners with global prime partners. So on top, we have Eswatini, and Eswatini we have the Royal Commission, or TLC, whose focus is community programs with the ART and Vmemc. In Kenya, we have Ampath, Moi Teaching Hospital, and recently we now have AMREF, both of them supporting Vmemc. And then in Tanzania, we have Association of Private Health Facilities of Tanzania, who are focusing on Vmemc. In Mozambique, we have a demand generation partner, Chova Communication Programs. And in Malawi, we have two transition mechanisms. One is Right to Care, and the second one is Catholic Health Commission. Both of them support direct service delivery, but Right to Care supports additionally demand generation and communication with clients. Next slide. On the next two slides, I will talk briefly about some of the contributions of our local partners to overall targets in the countries where they support. On this slide, I'll start off by speaking about the prime local partners in Eswatini, Kenya, and Tanzania. Overall, I want to mention that despite challenges, local partners have made tremendous milestones despite all of those challenges, especially the pandemic and onboarding challenges. Tremendous milestones because they have been able to onboard despite all these challenges. So Eswatini has the Local Commission. The Local Commission is an old local partner who has done well in the past, but this year they are struggling because of the pandemic and of course the age guidance. They were at 11% by the end of Q2. In Kenya, Ampath was at 52% towards the end of Q3, which is basically a great performance despite the fact that Kenya has suffered a lot due to the pandemic, lockdowns, and interruptions in services. In Tanzania, AMFTA was around 36%, which was a big jump from where they were by the end of Q2. They basically tripled their performance within about 3 months. Next slide. On this slide, the transition partners in Malawi did also receive targets, and briefly, CTC was around 73% of the target they received, and Right to Care Malawi was around 82% contribution to the PSI target overall. The demand generation partner in Mozambique doesn't have direct service delivery targets, but they contribute to demand generation to support the global prime partner. Next slide. I will now spend a few minutes to speak about some of the challenges with the Association of Private Health Facilities in Tanzania, some of the challenges they have overcome to establish themselves as the prime partner for Vmemc services. There have mainly been two challenges in Tanzania with AMFTA. The first one is funding delays, which is mostly related to the type of mechanism they have, the type of contract they are working with. This kind of contract requires that they provide results before they get funded, which makes it very difficult for them to operate. We've had several meetings led by the AQ local partner team, the Vmemc technical team, and the Tanzania AQ cluster team. In those meetings, we were able to speak to the COR, the OAA, and the Tanzania Vmemc team. We did receive guidance from the AQ local partner on provisions of advanced funding, which wasn't available for any local partner, yet this is actually available for global primes. We did get an opportunity to get their contract updated so that they can start receiving advanced funding, which was actually expected by the end of June, and I hope that that was received. We should be hearing from one of our colleagues working with AMFTA. Can confirm that. At the same time, they had been trying to organize funds using different approaches, and they did receive at least a bank loan followed by reimbursement for the services provided. So the funding challenge was resolved, and that actually contributes to the fact that they have improved in services. The second challenge that Tanzania has faced has been a delay in approval of the local partner to operate in government facilities. So we were expecting a memorandum of understanding to be signed, but this has delayed. The Ministry of Health wanted to include the client stamp 14 before signing this MOU, but we've worked alongside the country team to discuss ways that this can be implemented. So the MOU is pending signing, but we do have verbal approval to work in government facilities. Next slide. So on this slide demonstrates how the Tanzania team has really overcome challenges and to quickly improve their performance. They were at 11% by the end of Q2, but in just 3 months, they had almost tripled their performance from 11 to 36%. And we hope if there is no additional interruption due to the pandemic, the Tanzania team is likely to improve their services during Q4. So this is my second last slide. Next slide. We do provide here a couple of resources related to Vmemc. Thank you very much for listening. I hand over to Jane. Thank you.
Thanks, Valerian, for that excellent overview of our voluntary medical male circumcision programming. We're going to switch gears now and talk about condoms. So next slide, please. I'm going to jump back in here and do a quick presentation on condoms for you. Again, you're welcome to add questions, comments, or feedback in the Q&A box. We've had a couple of questions come in, which we've answered in writing, and then a couple that are outstanding that we'll address at the end of this part 1 of the webinar. For my piece on condoms, I'm going to talk a little bit about the global situation, provide some data on condom use, talk a bit about PEPFAR's Cop21 priorities for condoms, also give some information on procurement, and then I also want to just talk a little bit at the end of my presentation about USAID's engagement with the Global Fund on prevention, particularly condoms. Next slide, please. So in this slide, you can see the current global condom situation. And as you'll see and hear, there is a bit of cause for concern. Unaids 2020 target of reaching 90% people of Unaids 2020 90% target for condom use was not met in the last several years and was even out of reach in some places of the globe. We also know that condom budgets have been significantly reduced over the past decade, and in particular, social marketing programs in sub-Saharan Africa have really been slashed. There's also a new generation of sexually active young people that has not been exposed to the intense condom promotion that was in place 10 to 15 years ago. I don't know about many of you, but for me, I've been working in this area for over 20 years, and I do recall the focus on condoms was much, much stronger in the 90s and early 2000s, but that's really changed in recent years. We also know that key populations in dozens of countries across the globe are unable to access multiple HIV prevention services, including condoms and lubricants. And in some countries, the addition of lubricants is not even legally allowed. And it also appears we're seeing a shift in condom use to oral PrEP use due to perceived higher protection. Of course, oral PrEP has very high efficacy, but condoms are still recommended to be used with oral PrEP for other sexually transmitted infection prevention and also unintended pregnancy prevention where needed. Next slide, please. In the next few slides, I just wanted to show a little bit of data about what's been happening around condoms around the world. You see here that male condom sales through social marketing has declined over the past decade, particularly since about 2009, 2010. Next slide. In this slide, a couple of things. You see that condom use across all of Western and Central Africa and Eastern and Southern Africa remains very low, and it's also decreasing among AGYW in 8 countries in these regions, 5 countries in Western and Central Africa, and 3 countries in Eastern and Southern Africa. Also, while I haven't provided a visual, condom use at higher risk sex among men declined in 5 of 19 countries in sub-Saharan Africa, based on Unaids estimates. In my next slide, I put in a visual from the Unaids Condom Scorecard. Unaids has a number of scorecards that they put out on a regular basis related to prevention. There's one on KP programming, on AGYW programming, Vmemc, and other topics as well, but including the Condom Scorecard. And in the Condom Scorecard, there are a number of outcome and output indicators that they're tracking across the globe. In this slide, you see the scorecard for a number of countries in Africa, and it really tells you kind of how countries are performing with the green, light green, yellow kind of showing fairly good to medium to good performance, and then the orange and bright orange showing poor performance. I won't go into details now, but you can see here on the scorecard some of the indicators related to condom use with non-regular partners, among women and men, knowledge of condoms as a prevention method, number of condoms distributed or sold, and also condom needs. So you can take some time to look at this later, and this is available online at the link that you see on the bottom of the slide. Next slide, please. So given the current situation with condoms, PEPFAR has outlined a number of condom priorities for COP21, and you see all of those listed on the slide. The PEPFAR goal for condoms is high levels of use, equitable access to, and sustained demand for condoms and lubricants among key and priority populations, as well as low-income groups. Some of the priorities include integrating condoms with other service platforms as part of informed choice and client-centered approach. PEPFAR promotes the integration of condoms in Vmemc, in HIV testing services, care and treatment, PrEP, dreams, key population, programs to engage men, and other community activities. PEPFAR also prioritizes demand generation, and it encourages partners to employ a range of approaches to address barriers in conjunction with other program areas and also limited social marketing activities. There is a very significant emphasis for PEPFAR on providing technical support to governments for greater stewardship, leadership, and oversight around condoms. And also, countries are encouraged to plan for governments to fund and manage free brands of condoms. Also, a priority is fostering an enabling environment for a total market approach, and where needed, to identify in countries a market facilitator to support this. And the role of this the importance of this work really is to enable a more total market approach to condom programming that encompasses both the public sector and the private sector, including socially marketed condoms as well as commercial condoms. PEPFAR also wants to see a phase out of procurement and supply support for branded social marketing of condoms, and they really want to avoid investments in branding free condoms, except maybe where data suggests it would help drive use. So these are the condom priorities for COP21. In the next slide, I just wanted to share a little bit of information about procurement of condoms. And here you see that in COP21, we have approximately $20 million that's been set aside in the Central Condom Fund here at headquarters. And this level of funding for the procurement of male and female condoms and lubricants is about the same level as we had in COP20, even in COP19 and before. Most of this $20.3 million for COP21 has been allocated for procurement of condoms and lubricants to the countries that you see here. There are 17 countries in Africa receiving funds for condom procurement, also one in Eastern Europe, as well as 6 countries in the West Africa region. I also want to point out that for the first time in this COP21, we have worked with SCAC to set aside a portion of funds for what we are calling a buffer reserve. And that is meant for condom procurement to cover unexpected or emergency requests for condoms during the year. This would be outside of the country operational plans that each country actually submits each year. Thanks. Next slide. Before closing, I also wanted to just highlight the importance of USAID's engagement with the Global Fund around prevention more generally, including PrEP and Vmemc, but also in the case of my presentation around condoms. And we recently have had a couple of technical exchanges with the Global Fund, with their colleagues based in Geneva, the headquarters for Global Fund. And we're trying to really work to increase our technical collaboration and coordination with them related to prevention programming for both for both the implementation of interventions on the ground, but also related to supply chain. So we've had these technical exchanges, and through those meetings that we've held, Global Fund has identified for us really some of their main prevention priorities. And I thought you would be interested to see this. They definitely have a strong renewed focus on scaling up prevention interventions, including condoms. They also want to strengthen their support and monitoring of prevention programs, that is, interventions for programming condoms, not just the procurement of condoms. In the past, as you may know, Global Fund has invested a great deal of funding in condoms, but just for the supply side of it. They haven't done a whole lot on the programming side, and that's something that they're hoping to change in the future. They're really hoping to focus on precision prevention, looking at really the distinct needs of the different populations that are being served with prevention interventions. They will continue to procure commodities, but they also want to optimize platforms for multiple prevention methods. So, for example, as the dapivirine vaginal ring or the long-acting injectable cabotegravir come onto the scene, looking at how they can incorporate that into ongoing PrEP platforms. They're also wanting to encourage countries to prioritize choice in HIV prevention. This is especially important given the new prevention products that are in the pipeline. And they are looking at investigating options for incorporating sexually transmitted infection screening into HIV prevention. They would like to build on COVID adaptations and innovations. And they are also, like us, very keen to collaborate with USAID to really look at how we can catalyze resources for condoms. So I added this slide because while this really kind of tells you about the conversations that we have had at the headquarters level, the Global Fund plays a very important role at the country level. So we encourage you as implementers of USAID partners, of USAID's Office of HIV/AIDS to find opportunities to link with the CCMs at the country level for the Global Fund, because it's really there where much of the decision making and programming is done, and having those connections, I think, is going to be really important. In 4 places in particular, next slide, I want to highlight a strategic initiative for condoms that the Global Fund is undertaking, because I think there may be opportunities for our local partners working on HIV prevention to link with this work. So just a little information about that. For 2020-22, countries were able to apply for what was called catalytic funding for condoms. And this was funding that was complemented by $5 million in matching funds from the Global Fund. Unaids is going to be contracted to do this work over the next 3 years. And the 4 countries who were chosen for this catalytic funding were Malawi, Mozambique, Uganda, and Zambia. And the focus of this strategic initiative for condoms is really to advance national leadership and coordination, to improve market stewardship for condoms, to support condom strategy development in places where one doesn't exist, strengthen national and subnational systems for program management. The initiative will also support improving data systems to monitor needs and supply of condom, but also preferences for condoms. And then it will also include increasing innovations in demand creation and last mile distribution for condoms. So USAID PEPFAR really encourages our partners, both international and local, to look for opportunities to create linkages with this work, especially given that we are supporting condom programming in the 4 countries that you see listed here. So that's an overview of condoms. Next slide, please. All right, so we have reached the end of part 1, where we've looked at different HIV prevention interventions, PrEP, Vmemc, and condoms. And now I want to open it up just for a few minutes for questions. And we'll also take a few minutes to hear from a couple of our local partners with some reflections. All right, give me a moment just to check the Q&A. We did have previously a couple of questions on PrEP use by AGYW, I think related to continuation. There was one on the PrEP new indicator and one on use of virtual platforms for PrEP. And I think those have been answered, so you might want to check the Q&A box for that. There's also been someone talked about PrEP for serodiscordant couples, saying that they hadn't done that yet. But I think, that's a really important area and population to be served with PrEP. So to the extent that you can advocate for that in your country, I think it will be really important. And then let's see. We have a couple of questions in the box. One comes from Juliette. She is in Cameroon, and she was saying, could we add advocating with government stakeholders for the inclusion for priority population as AGYW for PrEP dispensation? I think that's a comment from Juliette. And certainly, I think, as PEPFAR and Usaid, we definitely are advocating with governments to include AGYW for PrEP dispensation. I think that's a really important piece of our DREAMS work, which you'll hear about shortly. So thanks for that. And I think there was also an answered question. There is a question in French. I'll ask some of my colleagues to answer that if possible. I also see a question from Monique. She says, HIV testing is mainly considered as a dimension reserved for girls and women of bad reputation at her organization in the DRC. She then says, hence sensitization and dialogues are the prerequisites for HIV prevention. Thanks for that comment, Monique. I don't know if any one of our panelists want to respond to that or any of the other questions. I'll open it up. Anyone have thoughts on the questions that were shared? Okay. Another question just came in, I think from Zanzibar. Sunday's saying there's a challenge of condom accessibility in Zanzibar due to cultural settings that does not form open channel of distribution in form of social marketing. How will accessibility be ensured in Zanzibar? That's an interesting question, actually. Thank you, Sunday. I actually used to work in Tanzania, and there are a couple of social marketing projects in Tanzania, including those that are run by PSI and also TMARC. I think that would be a place to start to look at how to ensure access and distribution in Zanzibar. If others have responses to that, please feel free to chime in. Euro from Tanzania is asking, how can we improve condom reporting and PEPFAR programs beyond condoms distributed as part of FP? Ooh, that's a great question, Yero. Unfortunately, I think one of the things, as you saw from my presentation, is that we don't actually have very good indicators for tracking condoms. In our PEPFAR world, the only indicator that we use, and it's not even a MER indicator, it's ones that our supply chain folks are using, a program indicator for looking at distribution. I think this is an important question that we're really grappling with here at OHA, and it's one that we want to actually take up in the coming months with our colleagues at SCAC to really work with SCAC to find out really what they see as priorities for condoms going forward. We haven't had those meetings quite yet because we've been waiting for the new ambassador to come on board. So once that happens, this is definitely a priority for the agency. Okay. Any other questions? I see that Kate has added some wonderful resources in the chat box on materials for AGYW and PrEP. So I would encourage folks to check the chat box for that. Please keep the questions coming. I also would like to take a moment to ask two of our local partners to just share some reflections about their prevention programming. So I'm going to first start with Isabel Mendez-Siamba. Isabel is from the IntraHealth Namibia in Windhoek. And Isabel, if I could ask you to please come online and just tell us a little bit about your prevention program in Namibia. And then if you could just share with us one notable success that your organization has achieved related to prevention, and then perhaps one challenge that you faced in your program and how it was overcome. Isabel, over to you.
Thank you so much. As it was indicated by the speaker, my name is Isabel Mendez-Siamba. I'm the Chief of Party for the KP-STAR project. One of the successes that we had in the project, I think before I talk, the KP-STAR project is a 5-year project. It will be implemented starting we started last year until 2025 February. And the objective of the KP-STAR project, or one main goal of the project, is actually to ensure that we strengthen HIV prevention for key population and other HIV key population programs while scaling up innovative evidence-based approaches to reduce the incident and mitigate the impact of HIV among the key population. So we are in the consortium of partners. We have about 5 key population-led organizations in the consortium, and IntraHealth Namibia is an overall partner that provide coordination to the key population-led organization. So one of the main success that we had was we had to look at, when the project started, we had to look at how do we also keep ensuring that at the end of the project or beyond the donor funding, there is sustainability of the project between key population and also government moving forward, and also to look at improved service delivery. So what we did as a project is to really look at providing orientation to the Ministry of Health regional team, including the national team, district coordinating committee, pharmacists, and nurses at the various health facilities and regions. So this basically also led to an improved service delivery for the key population. We were also seeing nurses and doctors identifying sex workers, MSM, from the facility level and referring them to the community for the KP-STAR project staff. And we've also seen an understanding of and less actually cases or reports on stigma and discrimination. So there's actually an improved relationship between key population and the healthcare workers. So what we've also done is the formation of the KP technical working groups. And this technical working group, they are spearheaded by the Ministry of Health. As I indicated, we wanted like ownership for sustainability purposes. We provide funding, but the Ministry of Health take ownership in calling meetings. And these key population technical working groups consist of nurses from various health facilities, whereby they meet on a monthly basis to talk about challenges, they talk about successes, and also devise new ways for improvement. Not only that the platform of the KP technical working group is only by healthcare workers, but we also have the key population themselves sitting on that platform, where they also air their grievances, and the nurses discuss and go back to their health facilities to talk about what the claims and the challenges that the key population are experiencing. And one innovative way, I think I not include in the beginning that the key populations program started really at the stage when Namibia was just going into a lockdown, and we had to be very creative to ensure that we still reach out and ensure that we provide services. So what we have also we then also introduced a quick an online application that allow people to make bookings and appointments online. So this is also one of the key innovative that was success that we implemented under IntraHealth Namibia to ensure that despite COVID, the key population still get services or are initiated on PrEP. And just quickly to share some data of over the period of 12 months of what we did and how to emphasizing on how many key population we screened. So we screened about 11,518, and from those whom we screened, 7,856 were eligible, and a total of 3,060 key population were successfully initiated or started on PrEP. So for Q2, we have a target of 2,325. We have already initiated about 1,582 on treatment. One thing that I wanted to highlight also is actually on the MSM for FY21. We had a target of 394. For FY21, we've already reached 349. So one asks what is for MSM specifically. So in Namibia, it's not so easy to reach out to MSM. I would say we have reached already 89%, and this is due to the strategy that we implemented that we called a POR, where we identify MSM through various platforms, especially on social media, and we then hand over HIV self-testing. And we follow up, we provide information on the advantage of getting testing for HIV, and all those who test negative, we then enroll them on PrEP. So one challenge that we experience in the program is misinformation among communities about PrEP. That has been easily access to PrEP for those who are eligible, and also the packaging. This stigma related to PrEP packaging, something is ARV. So this has led to some of the key population cycling off. However, this is being slowly overcome by educating the clients right at the beginning that PrEP is not the same as ARV. So we just provide more information to the client, and I think we are really overcoming that challenge. And also one of the challenges that we're experiencing is client migration leading to treatment interruption, sometimes on PrEP. Thank you.
Thank you, Isabel. Thank you for that information from Namibia. Could I also ask Maligo Rafael? He's from the Association of Private Health Facilities in Tanzania, or AFTA, to hop on the line. Maligo, we'd really appreciate it if like Isabel, you could tell us just a little bit about your Vmemc project, and then one notable success and challenge that you faced. Over to you, please.
Okay, thank you so much, Jen. Thank you for the introduction. My name's Maligo Rafael. I'm the Chief of Part for the Usaid Vmemc project that is being implemented by AFTA. AFTA being an association of private facilities in Tanzania, covering and being an umbrella of all the private facilities in the country. We are the contractor of Usaid on the Vmemc implementation. A project that was awarded July 2020, being transitioned from an international organization, JAPAIGO, going to a local implementing partner. So the very first time that we as local implementing partner implementing these kinds of interventions and being a direct implementer for USAID. We are implementing this project in 5 regions, high priority regions of USAID, and we work together with the Ministry of Health, the local government authorities, together with other stakeholders. We're implementing a new mechanism, completely new. It is the first time to have this kind of contract being implemented in Tanzania. It's a fixed price contract where we do circumcisions using our own internal resources, and then verify the clients, and then send invoices to Usaid to get some funding to be able to implement the activities. So we've been in the field operations for the past 1 year, and we have actually some successes and challenges as well. One of the successes that we have is the fact that we've been able to implement 100% new age eligibility for PEPFAR that focuses on reaching 15 years, boys and men of 15 years and above. There's no circumcision of anybody who is under 15 years. That's by itself, is a success. We've been able to reach, the first presenter presented, about 41,000 boys and men 15 years and above, excluding all under 15. One of the challenges that we've had is the fact that we are implementing a program in an environment where there's a contradiction between PEPFAR guidance and what the Ministry of Health is doing. For the Ministry of Health, they are implementing Vmemc across all the adjuvants, including early infants, as well as 10 to 14. We support the same facilities that are doing that. And we've succeeded, introducing this across all the levels, right from the Ministry of Health, the Ministry of Local Government Administrations, but also going down to the regions, the districts, the councils, the wards, and the villages. And the project is kind of being accepted after we had lots of meetings, introductions at different levels. And the other success that is attached to that is the fact that we've been able to engage the Ministry of Health, the local government authority, and other stakeholders at different levels to come up with a memorandum of understanding whereby the government now agrees that this project is going to focus on 15 years and above boys and men. And we have been able to agree on a tool that selects and reports only 15 years and above through the DATIM, but also supporting the site to report anybody who is circumcised who is under 15 years through the national DHS system. So that's in a nutshell what we are doing, and we are very much happy to have been received support from Usaid, especially on adjusting the contract and making sure that we have advanced funding that goes hand in hand with the new firm-fixed contract mechanism. Thank you very much.
Great. Thank you so much, Malika. We really appreciate that perspective from Tanzania. Thanks to both you and Isabel for sharing some reflections during this part of the webinar. Let's move on now to the next part of the webinar, which is really looking at evidence-based prevention responses focused specifically on two different populations. Next slide, please. Our first presentation is going to be on key populations, and that's going to be given by Sarah Yeiser. Sarah is a key populations advisor with the Office of HIV/AIDS. So Sarah, over to you. Thank you.
Thanks, Jane. Hi everyone, my name is Sarah Yeiser, and I'm a KP advisor, like Jane mentioned, in the Office of HIV/AIDS, and also work quite closely with many of the individuals you'll have heard from today. So like Jane said, I'm going to discuss the prevention programming within Usaid for key populations. Next slide, please. Many on this call, I'm sure, are already aware of these data and work with key populations within your programming, but globally, as already mentioned, key populations are defined by Unaids as MSM, FSW, TG, PWID, and people in prisons and enclosed settings. And these individuals are disproportionately affected by HIV and are at the highest risk for HIV infection compared to the general population. And this is irrespective of the epidemic type or local context due to specific behavioral and structural factors. You can see there the latest data show that among HIV infections in 2019, 62% occurred among KPs and their partners. So which, this is obviously a significant and alarming number, and this is why Usaid has specific KP programming. And obviously, I just wanted to mention, not all KPs are the same. There are differences within and between KP types. Many KPs have overlapping or various identities or behaviors that also impact HIV risk and vulnerability, like for instance, a KP's age, gender, or even belonging to numerous KP groups, for instance, a transgender sex worker. And like I mentioned, KPs are often marginalized and many factors influence their risk, which are largely outside of their control. This includes various social, legal, structural, and other contextual factors that both increase vulnerability to HIV and obstruct access to HIV services. This includes punitive legislation, policing practices, stigma and discrimination, poverty, just to name a few of some of the reasons why KPs are at greater risk of HIV acquisition and onward transmission. Next slide, please. So given this background, we know that in order to reduce new infections globally and to end the HIV epidemic, at-scale prevention services for key populations is imperative. You can see in the map on the right, USAID funds HIV programming, including prevention programming for KPs across over 40 countries. And just listed out here are some of the main key components to combination prevention programming for KPs, and I'll mention a few. The main priority is to ensure that programs are tailoring prevention programming to each KP type and their specific needs, and ensuring that services are client-centered, which includes ensuring, for instance, differentiated service delivery approaches for prevention. For example, implementing service delivery within a community drop-in center, or hosting nighttime clinic hours, or incorporating routine mobile outreach and testing, or for instance, community initiation and dispensation of PrEP. Other cornerstones of evidence-based and combination prevention programming is implementing behavioral and biomedical interventions that have already kind of been outlined, but for example, providing counseling or other psychosocial support, or scaling up PrEP for KPs, or for example, providing STI diagnosis and treatment services. Another key component of addressing the underlying issues related to HIV acquisition risk and onward transmission within KPs is ensuring program uses a rights-based approach to create an enabling environment for services to increase access by addressing stigma, discrimination, violence, legal and policy barriers, and some of those that I already mentioned in the previous slide. Lastly, a big focus of our programming is working with and funding local KP-led and KP-competent organizations, and engaging the community in the design, development, implementation, and evaluation of programming, which is key to ensuring that programming is client-centered and meets the needs of the community, and that overall that the response is sustainable. Next slide, please. Before I go over kind of the global trends and data from USAID, I wanted to highlight the relevant MER indicators. This chart outlines the definition and code of the indicators used to monitor and report progress within KP prevention programming, as you can see there. I'm not going to go into depth on this, but wanted to highlight that KP disaggregates are required within all of these indicators, excluding KP MAT, unless there are approved reasons for not collecting this information, for example, due to safety or security issues, which the MER guidance goes into more detail related to those stipulations. But also wanted to highlight that, KP Prev, which is reported semi-annually, helps partners understand reach within their program. And in addition to the KP disags, they're also testing disags within KP Prev, as outlined here, which helps program understand the status of the KP's reach and whether they might already be HIV positive, or if they need testing services. In addition, in order to meet the requirement to report on this indicator, HIV testing must be offered or provided to those KPs who are reached within the program, in addition to at least one additional listed prevention activity as outlined in the orange box, which highlights a few more examples of evidence-based behavioral and biomedical prevention interventions. Next slide, please. So moving on to review current global KP prevention data, we can see here USAID's global prevention cascade, which starts with KP Prev. And then the KP Prev testing disaggregate results are represented in the second bar. And the percentage above that bar, you can see that represents the number of KPs reached within KP Prev that were identified as being referred or provided testing through USAID programs. And the third bar actually showing the USAID results for tests among KPs. So, you can see the trends over time, but if the trends continue, USAID will continue to increase our reach to over 1 million KPs globally this fiscal year, These indicators and disaggregates show that USAID programs are quite efficient at reaching KPs who are potentially most at risk and that are negative and eligible for HIV testing. This is due to the nature of how KP programming is implemented within USAID, including optimized network-based approaches and more client-centered approaches. Next slide, please. And then looking at a key component of the prevention cascade, which is linkage to PrEP, for those KPs who test negative, you can see that USAID programming continues to increase linkage rates over time. And during the last quarter, programs reported a 12% linkage rate. I should say this is a proxy measurement, and there are certain limitations and nuances to this interpretation, but for the sake of looking at trends over time, it is promising and a focal point of programming to ensure that partners are continuously improving service delivery and tailoring approaches to ensure that those that we do reach and test that are highest risk of HIV have access to PrEP in a client-centered way. Next slide, please. And this slide here, you can see in fiscal year 20, there are about 66,000 new PrEP initiations for KP within USAID programming, with a quarterly average around 16,000. This year, like many have noted, PrEP targets increased significantly for many OUs for KPs. And you can see here that PrEP continues to grow among KPs with the Q2 results PrEP initiations exceeding results from quarters Q3, Q4 in fiscal year 20 and fiscal year 20 Q1 results. So you can also see PrEP curves continues to grow, showing the growth of PrEP within our programs for KPs. Next slide, please. And this graph here also highlights the significant and recent increased uptake among FSW and MSM within USAID programming. There's still work to be done for other populations. However, MSM and FSW are the largest populations reached within USAID programming. So it's exciting to see this growth over the past few quarters. Next slide. Thank you. So here I list out and highlighted specific challenges and opportunities for prevention programming for key populations. I won't go into too much detail given the time limits, and a few of these things have already been identified by other presenters, but a major challenge, especially during this COP year, was that many of the key populations prevention budgets were flatlined or even decreased. With an increased expectation of PrEP scale up and increase in client-centered DSD models. So with the focus of ensuring that we link all those tested and negative to PrEP services, it really pushes partners to be as efficient as possible and can be quite challenging. Another challenge related to PrEP scale up has been that kind of the slow expansion of community PrEP initiation and dispensation, which I mentioned our USAID priorities, but this also is impacted by budget, but also various other policy restrictions, HRH limitations, and COVID impacts. And speaking of COVID, we all know that that's presented, huge challenges, and that's the same for KPs and prevention programming. So the focus has been on ensuring that essential prevention services are maintained through adjustments of programming in a safe way, and that there's continued access to prevention services and commodities. I should mention, though, also in particular, there have been many social issues that have been exacerbated by COVID and have impacted KP specifically, including increased food insecurity, economic vulnerability, and increased stigma and discrimination, which has impacted KP's ability to stay engaged in care and also increase their risk for HIV acquisition. There are a few other things I listed here, but in the interest of time, I wanted to highlight that despite these challenges, there are also many opportunities to expand and improve prevention programming for KPs, including the continued focus on expansion of DSD models to ensure that programs are meeting clients' needs and preferences and increasing access to PrEP. It's also imperative that we continue to empower civil society and communities to be at the center of the response through continuous engagement in our programming, and especially in the monitoring of our programming. And also that we focus on funding and engaging KP-led and KP-competent organizations to ensure that our services are meeting the needs of the community. And lastly, I think I've listed out a few other things, but I just wanted to highlight U equals U and the power of that messaging. Many OUs, in addition to scaling up access to optimized ARV regimens and DSD models for ART and viral load to ensure KP positives are virally suppressed, Countries have also rolled out various U plus U campaigns, incorporated it into provider messaging within all aspects of programming across the HIV cascade, which not only increases demand for HIV services like treatment and viral load for those who are HIV positive, but also promotes viral load suppression, which lowers HIV transmission, but also increases demand for testing, knowing your status, and for PrEP and other prevention interventions. I think, next slide. So I think that's it from me. I just wanted to highlight those few things and kind of the priorities of USAID KP prevention programming. So I'll stop there and just, these are additional resources that might be useful to you all as well. Thanks, Jane, and that's it for me.
Great. Thanks so much. Thanks so much, Sarah, for that very informative presentation. Let's now move on to our last presentation, which is going to be on adolescent girls and young women and taking a closer look at our DREAMS programming. And so Erin Shaler, who's a gender advisor with the Office of HIV/AIDS, will be presenting on AGYW. So handing it over to you, Erin. Thank you.
Thank you so much, Jane. Happy to be here today speaking about prevention among adolescent girls and young women and our DREAMS program. Next slide, please. As highlighted here, adolescent girls and young women, or AGYW, are at particular risk for HIV and have higher rates of infection than their male peers. It will be impossible to achieve an AIDS-free generation without addressing the impact of HIV on this population, and therefore also the intersecting biological, behavioral, and structural factors that directly and indirectly fuel AGYW's heightened risk of HIV infection. Next slide, please. To address AGYW's multifaceted vulnerabilities and HIV risk, DREAMS was announced by Ambassador Birx on World AIDS Day 2014. It's an ambitious initiative to reduce new HIV infections in AGYW. DREAMS has evolved from a 2-year centrally funded partnership in select high-burden geographic areas in 10 countries to become the standard PEPFAR HIV prevention approach for AGYW aged 10 to 24, funded in the PEPFAR envelope, now implemented in 16 countries. Next slide, please. A fundamental principle of DREAMS is the layering of evidence-based programs and services to ensure that the complex needs of adolescent girls and young women are met. The principle of layering is based on research showing that comprehensive care is more effective than standalone services. In this diagram, you can see that DREAMS funds a core package of evidence-informed approaches that go beyond the health sector, addressing the structural drivers that directly or indirectly increase girls' HIV risk, including poverty, gender inequality, sexual violence, and lack of education. The core package of interventions addresses HIV prevention for the most vulnerable AGYW through work with 4 overlapping populations. Among AGYW, interventions aim to empower girls and to reduce the risk for HIV and violence. This includes development of relationships with mentors as part of safe spaces. Secondly, their families. Interventions for this population aim to strengthen the family economically, as well as in their ability to parent positively for younger age bands. Third, targeting their male sexual partners with highly effective HIV interventions, including Vmemc and antiretroviral treatment. Lastly, their communities. These interventions aim to mobilize communities for change to keep girls HIV-free and safe from violence and address gender norms. Next slide, please. I'd now like to share an example of what the specific services might look like for each component of the core package. The exact services provided varies by country, but always include evidence-based approaches in line with PEPFAR guidance. Services are determined by age and are packaged by primary, secondary, and contextual activities. Services in the primary package are intended to meet the immediate needs of adolescent girls and young women and should be received by all DREAMS participants. Secondary services are needs-based for those in a particular age band. For example, most 10 to 14-year-olds will not need contraceptive method mix, but if they're married or sexually active, then they should receive that service if desired. Contextual services address other critical vulnerabilities associated with HIV risk, not delivered directly to beneficiaries themselves, such as community norms change through SASA. Each country has their own package based on their context, and every country also delivers their dream services differently. For some countries, one partner in one district may provide all of the primary and secondary interventions. In other countries, multiple IPs may provide all of the primary interventions, and one IP may provide the clinical interventions, even within the same geographic area. Interventions can also be provided at different service delivery points in different countries. For example, some countries may implement mobile clinical services, while other countries may implement clinical services in government facilities. Other countries may have one-stop centers for DREAMS, where all DREAMS services are provided at one location. We'll have the opportunity to hear from one of Rwanda's local partners during the Q&A about their experiences implementing the program. Next slide, please. DREAMS is now programmed in 16 countries in Africa and also including Haiti. Data from the most recent quarter demonstrate that 1.6 million adolescent girls and young women are currently enrolled in the program. Because of the multiple services offered via DREAMS programming, the initiative requires significant collaboration among PEPFAR agencies and implementing partners to ensure both referrals between entry points, which may span from clinics to communities, to reach beneficiaries with a complete package of services based on their needs. Next slide, please. DREAMS strives to reach AGYW at greatest risk of HIV acquisition in the highest burden districts in which PEPFAR works. Thus, in addition to determining the most appropriate interventions for a given country context, each country program determines risk factors and vulnerability criteria for participation in the DREAMS program based on the local context, the latest evidence, and in line with PEPFAR guidance for vulnerability criteria. This visual highlights work by the team in Namibia to outline relevant risk criteria for DREAMS enrollment. AGYW meeting any one of these risk factors of criteria are eligible for enrollment into the DREAMS program. Some examples of these include history of pregnancy, exposure to violence, and engagement in transactional sex. Next slide, please. The PEPFAR prevention indicator designed specifically to monitor the implementation of DREAMS is AGYW PREV. This measures the percentage of adolescent girls and young women who completed at least the DREAMS primary package of evidence-based services and interventions. While AGYW PREV tracks the layering of services for beneficiaries, the specific services that DREAMS girls receive as part of the core package will continue to also be counted under other MER indicators as appropriate. In this way, AGYW PREV is complementary to other MER indicators currently used to report on DREAMS and PEPFAR at large. For example, if a beneficiary receives PrEP through DREAMS, she would be counted under PrEP New and PrEP Cur as appropriate, and this would also count towards her secondary package under AGYW PREV. Implementation and tracking of layered services presents distinct challenges, especially in cases where several implementing partners are operating and working to refer AGYW between and among the different partners. AGYW PREV is unique in that it does not capture the work of one specific partner, except in cases of strict geographic rationalization, but rather whether partners are coordinating and effectively co-planning and monitoring to identify those most vulnerable and refer them to the DREAMS program, retain them, and deliver appropriate services. Next slide, please. This visual shows AGYW PREV data from FY21 to capture completion of the DREAMS layered package of services. I want to highlight two things. As you can see in the purple, we expect that completion of the DREAMS primary package of services and needs-based secondary services is not a rapid process, but we also do not expect beneficiaries to remain in the program indefinitely. Generally, we anticipate participants should be in the program at least 6 months to align with the USAID positive youth development approach, in particular for our youngest AGYW. Secondly, for a variety of reasons, the DREAMS program cycle differs by age band, with the 20 to 24-year-olds typically either needing to complete the package more rapidly or having other life factors that require adaptations to be retained in the program. Next slide, please. PEPFAR COP guidance for Cop21 and Cop20 highlights some key technical priorities which USAID has been supporting in our DREAMS program implementation and planning. I've already highlighted some of the primary priorities related to ensuring the highest risk beneficiaries are identified and enrolled and complete an evidence-based package of services delivered with quality and fidelity. Additionally, USAID priorities include enhancing mentoring approaches, accelerating PrEP uptake and continuation, economic strengthening, continued capacity strengthening for local implementing partners to support maintenance transitions, and continuing to address harmful social and gender norms through the contextual package, which we recognize takes more time. And this has also been a key point highlighted in the early findings released from the DREAMS impact evaluation. Next slide. The COVID pandemic has disrupted health and social services worldwide, with particular impacts on our prevention programming. In particular, DREAMS relies on the Safe Spaces platform and other means of connecting in person, in group settings, and lockdowns have also impacted entry points such as schools. While programs are innovating and adapting, the continued impact remains to be determined, especially in the context of many OUs facing third waves of lockdowns, such as in Uganda, Namibia, and Zambia. Programs have worked to mitigate the impact of COVID lockdowns through providing online and social media messages, including through WhatsApp, SMS, and Facebook, and sometimes home delivery of drugs and testing. But these measures do not replace the DREAM services. For clinical services, including SRH and HIV, the pandemic has created disincentives to go to health facilities, a situation even more acute for SRH and youth-friendly services. The shift to online or virtual forums has presented particular challenges for AGYW, since at-risk adolescent girls and young women often do not have smartphones or cell phones to participate in such virtual programs, or cannot afford airtime or data, or they rely on the phones of family or boyfriends, which raises important privacy and confidentiality concerns. Accordingly, efforts by mentors and peer educators to stay connected with the AGYW participants become more challenging and require redoubled efforts to maintain those connections. In Namibia, for example, virtual telephone assessments are being used to identify and provide critical needs to DREAMS AGYW, such as sanitary supplies, condoms, essential household services, and referrals for post-GBV care. PEPFAR has regularly issued COVID-specific guidance for continuity of programming and addressing frequently identified challenges and solutions. Next slide, please. Lastly, I'd like to highlight a few publicly available resources in addition to the PEPFAR COP guidance, which includes the latest DREAMS priorities. Thank you so much. I'll turn it back over to you, Jane.
Thank you, Erin. Really appreciate that overview of AGYW prevention programming. So now we'll just quickly move into our Q&A and local partner reflections. I'll start with a local partner and ask Charlotte Usanase and Wilson Kabagamba from the African Evangelist Enterprise in Rwanda. If one of you could come online, that'd be great. And briefly tell us about your DREAMS program and share one notable success and one challenge that you've faced in your program and how it was overcome. Wilson or Charlotte?
Yeah, thank you so much, Jen. I'm Wilson Kabagamba, as you have said. I'm the program director for Ubakejo. AEE Rwanda, as you have said, is a local civil society organization receiving direct funding from Usaid Rwanda since 2012. This organization, AEE, is implementing Ubakejo program, which is Build the Future in English. And we have been implementing this program since 2018. The DREAMS program under Ubakejo for AEE is covering one district, but in Rwanda it's covering 5 districts, AEE together with other implementing partners. Like other countries, DREAMS countries, our target, the program targets adolescent girls and young women at high risk of acquiring HIV, especially those with high levels of early sexual adults, history of STIs, adolescent pregnancies, transsexual sex, history of our current report of experienced violence, and engaging in sex work, as our colleague has mentioned. So far, the program has served 30,382 adolescent girls and young women in the age band of 10 to 24. And we have also served 1,120 beneficiaries in the category of male sex partners with a comprehensive multi-sector package of core interventions to address key factors such as gender-based violence, limited access to health services, inclusion from economic opportunities, and lack or limited access to education. I would allow my colleague Charlotte, who is with me, to talk a little bit more about the intervention and the success we have made so far. Thank you so much.
Yeah, thank you so much, Rutan. Just to highlight some of the interventions and the care achievements. Yeah, through school-based interventions, as my colleague Ellen said, we have supported 24,000 young girls and adolescent women to keep them in school, since that's one of the factors that where we had a lot of irregularities in school or dropouts. And through social asset building, we have enabled to train mentors in both technical and soft skills, which include sexual reproductive health and rights. And also because these mentors act as liaisons between AGY and service delivery points, such as accompaniment to access PrEP, family planning, and HIV services. And through youth-friendly sexual and reproductive health care promotion, we have supported adolescent girls to access condoms in the safe spaces, as where that's the all the services are being provided. So this has increased uptake of condoms within the community because they don't have to go to the health facilities to access them. And also HTC, HIV testing, whereby we have facilitated high-risk adolescent girls over 25,000 to be tested through community mobile testing services, whereby they don't go to the health facilities, of course, in this COVID-19, whereby we have limitations to access services at the health clinics. But then the nurses come to the community safe spaces in a mobile way to provide HIV testing. This has really been very successful. And also even PrEP, the follow-ups, this has not stopped even during this COVID-19 because the services have continued to be provided. So one of the notable success that I could share is that the program has been successful at bringing integrated services to adolescent girls and young women in their communities through formal relationships with various stakeholders. Just to name but a few, one is the mobile community HIV testing that has been successful. Of course, have established formal relationships with health facilities, and they are able to come to the community, to the safe space, to conduct HIV testing and counseling, and also doing the follow-up, especially for the PrEP champions, to encourage them to access PrEP. The second, through the formal relationships, is the access to community safe spaces, whereby the government of Rwanda has been flexible to provide safe space. Of course, after since we have been shifting to from the health facility because we couldn't gather at the health facilities, so we have the activities continue to work even in the community, and they did not stop because of that strong relationship that we have with the government of Rwanda. And also, of course, because of the COVID-19 adaptations, we have this program adaptations of short-term courses of apprenticeships, which were extended to the communities to allow the pregnant mothers and teen mothers to access, this apprenticeship program, and to, of course, with their children nearby because they couldn't walk long distances. And with this support with the government, we've been able to enroll a lot of teen mothers to access this life skill program. And of course, with the financial support and USAID's flexibility of reprogramming the funding, we've got a lot of business groups from young women and adolescent girls who, with this new initiative of making face masks, you have seen a lot of young girls creating businesses, making reusable face masks, and this has really promoted the resilience among adolescent girls and young women, resilience against the shocks of this pandemic, because really it has not been an easy journey for them. This has really been very successful, especially as a result of this strong partnership with different stakeholders on board. So one of the challenges, of course there are many, but one key challenge that we have faced in this period is through the COVID-19 restrictions and promoting this virtual mentorship and coaching, there is low coverage or access to mobile phones because this virtual mentorship was been challenging and only in our district to have 69% of AGY who could be reached by phone. And because we need to really ensure that the AGY stay in contact with mentors. And out of those 69%, 64% belong to their parents. Their phones belong to their parents. So there's this issue of confidentiality, which is the key to the AGY mentorship. But of course, with that challenge, there is a way that we really worked with the government and also with the local authorities in our country to offer like official passes or permission for some of the mentors who have AGY that don't have phones to conduct home visits, especially with those that have special cases of violence, because we had a lot of cases of sexual violence during the lockdowns. And then, of course, the program provided protective materials to enable mentors to be safe-free, but also remain in contact with the AGY. So with this, that's the experience sharing from AEE Rwanda. And with this, I would like to stop here. Maybe I would respond to questions. Thank you so much.
Thank you so much, Charlotte and Wilson. Really, really happy that you were able to share the experiences you're having with your Dreams programming in Rwanda. I especially appreciate your reflections about the COVID pandemic, because across all of our HIV programming, you know, some of the greatest impacts have occurred in our prevention programming. That's where we face some of the greatest challenges in our PrEP work, in our Vmemc work, getting condoms to clients. We know also that there have been challenges reaching key populations and AGYW during COVID. So we greatly appreciate you highlighting that issue. But we also know that it is within these different prevention interventions and the work that we do to reach the various populations with prevention interventions, that's where some of the greatest innovation has occurred over the past 1 year to year and a half. So thank you so much for highlighting what you've done there in Rwanda around trying to adapt your programming to the COVID pandemic. In the interest of time, I'm just going to move us directly into kind of a final Q&A and just take a few minutes. If you have questions or comments, please feel free to add them to the Q&A box. We also had an outstanding question from Mulu Alem asking really about AGYW eligibility for PrEP, you know, and the need to initiate AGYW who are at high risk for HIV prevention, but they don't necessarily have a policy or guidelines in place for that. So to answer that question, I'm going to ask Allison Cheng to come on and say a few remarks about that. Allison?
Thanks, Jane, and thanks for the question. And you know, I think I just wanted to acknowledge that I know for each country context is a little bit different in terms of who are the at-risk populations that I prioritize for PrEP programming. But this is an area where we're hoping to be able to continue to expand access to PrEP to additional populations, particularly those at risk. I think that in you know, some countries, for example, will start with key populations, but will be hesitant to expand to AGYW, or they might have age restrictions around who can access PrEP without parental consent and issues like that. For that front, what I would just recommend is that we continue to work with our IPs and with those stakeholders in country to advocate for policies and guidelines that are supportive of at-risk AGYW to have access to PrEP where feasible. And I think Kate posted earlier in the chat bar some useful resources around the evidence base or how to scale up PrEP for AGYW, which I think are still relevant for this group. It is supported in our PEPFAR COP guidance for Cop21. But again, I know that accessibility and availability of funding varies by countries. So we'll continue to advocate and let us know how we can best continue to help our IPs with that work. Thank you.
Thanks, Allison. Appreciate those additional reflections. I know in the chat there were also a couple of questions around indicators, particularly PrepCur, which, as some of you may already know, tends to give us a lot of challenges. And I want to just make a couple comments about that. One is that, annually, PEPFAR or SCAC does do a MER refresh, and they seek inputs from the different USG agencies as well as implementing partners and missions to give feedback on the indicators that are used for PEPFAR. And this year, during that call for feedback for the MER refresh, there were a number of individuals and groups who made comments related to the PrEP indicators. So we are hopeful that we will see some changes to those indicators in the next iteration of the PEPFAR MER guidelines, in particular for PrepCur. So I know Maddie, she did put a couple of responses in the chat around PrepCur if you want to check those. But if there are some of you who are still interested in receiving more information about PrepNew or PrepCur, please reach out to us or let ASAP know, and we can send some additional information to you. Let's see. I also saw there was a follow-up remark from Sunday in Tanzania. He was making the suggestion that, especially during the COVID pandemic, to look at opportunities to provide bulk condoms, at least 3 months worth, to KPs and AGYW. And certainly this is something that I think our implementing partners are looking into across PEPFAR countries. This is also a priority across, also a priority for other donors. We have actually an HIV prevention, there's the Global Prevention Coalition that is led by Unaids and includes a number of donors: Global Fund, Unaids, UNFPA, the Gates Foundation, USAID, and this is also a priority that we're looking at. How can we do sort of multi-month dispensing of condoms during the pandemic? So that is something that I know a number of funders as well as partners are looking to. So thanks for that observation and suggestion, Sunday. Also, Lilian has put a couple of questions in the Q&A box in French. Unfortunately, I'm not a French speaker, so if by chance one of our panelists or resource persons would be able to answer that, that would be great. I don't see any other questions coming in the Q&A box or the chat. So we're also running out of time. So I think at this point, what I'd like to do is turn this over to Sangeeta Rana. Sangeeta is our branch chief for the biomedical prevention branch of OHA, and she's going to make just a few closing remarks for the session. And I will take this opportunity to thank you. I think it's been a really wonderful session, and I definitely am grateful for the opportunity to both present and to facilitate the session. So Sangeeta, over to you to make some closing comments before we end the webinar.
Thank you, Jane. And I want to just echo Jane's thank you to all of our wonderful presenters and panelists on this webinar, and also for the many participants that we have on this call, and for the very engaged and excellent questions that I think we all have thought about much ourselves, so appreciated the chance to think about those. So to close the webinar, I just wanted to take us back to the start of our session. And I think just note that, as we highlighted throughout the presentation in the Unaids statistics and goals, that we still have quite a few challenges and a way to go to really reach the need to accelerate our prevention efforts, giving the gaps continued new infections, particularly in the vulnerable populations that were noted by our presenters today. But I also wanted to take another moment to recognize the tremendous achievements we've made in our prevention programs to date, led by both the presenters and our many implementers on this call today. And I think it's been clear that all of our programs implementers across the board have really stepped forward to bring essential prevention services to those who need them, particularly as we've noted today. And I think just recognizing the extreme and continuing challenges with COVID escalations. And I think on that note as well, I'll just say that we do hope this webinar has helped to highlight the really the strong approaches that we have in prevention and the strong interventions and tools that we have, and also support all of you on the call to continue to expand those efforts even further. I did see a lot of great questions in the box answered. As Jane noted, we would be happy to provide more information where we can, and we're always here to continue to support our prevention programs across the board. So with that said, I will just say thank you again to everybody on the call, and I hope everyone has a wonderful rest of their day or evening. Thank you.
Thank you all.
Thanks again to everyone. Have a wonderful afternoon and evening.